Good afternoon, everyone. Welcome to the afternoon session. So I have the pleasure to invite Dr. Ashutosh Marwah to deliver his talk. His talk is basically on when to intervene in child with congenital heart disease. Uh, Dr. Ashutosh Marwah is a distinguished speaker. He is a director of pediatric cardiology at Fortis Heart Institute, New Delhi. He is an alumnus of MAMC Delhi. He had been trained at pediatric cardiology at Royal Children's Hospital in Melbourne, and with more than 20 years of experience in treating children with congenital heart disease. So he has done a lot of international work as well. His area of interest is in cardiac interventions in newborn, intervention cardiac closure of cardiac defects like ASD, VSD, and PDA, coarct balloon dilatation, stent implantation in pulmonary arteries, and echo imaging in complex cardiac abnormality with fetal echocardiography. Welcome, Dr. Marwah. The stage is yours. Thank you.
Thank you, sir. Thank you for your kind words, and I'm grateful to the organizers for inviting me to this session. Without wasting much time, I'll start my talk. It's a slightly lengthy topic, and I may exceed, so please let me know whenever I need to stop. Interventions and timings, their timings in common congenital heart defects. Heart is the commonest organ to be affected by congenital malformation, and incidence remains same world over. It's 8 to 10 per thousand live births. So in India, approximately 2.5 lakh children are born with heart defects, and almost 50% will have significant heart defects, and many of them will require intervention within first year of life. And 10% infant deaths in India still are due to congenital heart defects, and the number is actually more if we look at all the aborted fetuses also. So most important is correct timing for treatment, because that is what is going to give us the optimum results. So one has to know what is the exact diagnosis or the correct diagnosis. One should be aware of natural history of the condition, then benefits of intervention in terms of long-term outcome, quality of life, logistics, money, etc. And clearly, if there is any advantage of waiting, then one could wait. So unlike Western world, we have a lot of issues. We have our most important is the congenital heart defects are not covered under any insurance. So we have to follow, still we try and modify things. Evidence-based medicine is there, best practices, and we also have to consider the socio-economic status of the families. So we have our own guidelines, which are the Pediatric Cardiac Society of guidelines, but we do also look at AHA guidelines time to time. So this is, everyone knows this, 4 major classification of cardiac conditions: acyanotic heart disease, which is shunt lesions, and the valvular lesions, and then the cyanotic heart lesions, which includes the cyanotics with reduced pulmonary blood flows and cyanotics with increased pulmonary blood flows. So from a larger perspective, for a person, we have to divide timing of intervention as the age. So important will be, so most probably we'll group it as 3 or 4 major categories: interventions which are required in neonatal period, interventions which are required in infancy, that is beyond 3 months of life, then early childhood up to 5 years, and then late presentations and requirement based. So early neonatal period requirements are basically surgical corrections or interventions in cath lab, say obstructed TAPVCs, transposition of great arteries, duct-dependent systemic or pulmonary circulation such as aortic atresia, pulmonary atresia, aortic arch interruptions, and of course cath lab interventions for critical aortic or pulmonary stenosis in the neonate. Because these children tend to decompensate very early, without intervention they have very high mortality. So one has to maintain very high index of suspicion for a neonate who is not doing well, and the requirement for surgery or intervention may sometimes happen soon after birth, and even we have at times preponed the delivery of critical aortic stenosis because the LV was becoming dysfunctional. So we had to prepone the delivery and do the intervention on day 1 of life. So available interventions are, I guess, one of the most useful intervention which everyone should be aware is the prostaglandin E1, because this is life-saving in all the duct-dependent conditions, and 10 to 16 nanograms per kg per minute. It opens the patent arterial duct, and it is important. It will save lives in cases of aortic atresia, pulmonary atresia, severe coarctation, and transposition of great arteries without any VSD. But it's only a temporary measure. It can be utilized only for shifting the child or patient to a unit where the further care can be taken. Balloon atrial septostomy, another useful intervention. It's probably one of the oldest cardiac intervention, but its again relevance lies in it's a life-saving procedure, and wherever a child with a TGA is born and there is no way to do a surgical procedure or intervention and prostaglandin may or may not be available, then balloon atrial septostomy is life-saving. A balloon which is passed across the PFO into the LA and pulled back, creating a big hole. So is the pointer working? Yeah. So this is the balloon. And we can create a hole here in the intraatrial septum, allowing the mixing and saves the life. And the child can be transported. Similarly, cath lab interventions in neonates may be required for critical aortic stenosis or critical pulmonary stenosis. They are again safely carried out with 3 or 4 French sheaths. Results are very gratifying, though some may require interventions later on, but immediately they are the life-saving procedures. The neonatal surgeries can corrective repairs for TAPVCs, aortic arch interruptions, transposition of great arteries. These are all going to be the corrective repairs, that is one stage single repairs, whereas some may require a palliation. Palliation would be a BT shunt for pulmonary atresia or Norwood stage 1. They are again all going to happen within neonatal period because these are the duct dependent circulations. Then lesions that require treatment during infancy. They are usually large shunt lesions, usually or mostly post-tricuspid shunts such as large VSDs, large PDA, AVSD, aortopulmonary window, then TAPVC with unrestricted with heart failure, then transposition of great arteries with VSD, truncus arteriosus, and most TOF. I'm including TOFs here because most of the time we are operating tetralogies by 1 year of age. So during infancy. Then treatment in late childhood. So late childhood would be 4 to 5 years or as and when they present. So mostly, if you look at the number has gone down significantly, it's mostly the atrial septal defects, TOFs which have been left over, or patients who are going to require conduits, Fontan completions, and aortic stenosis and pulmonary stenosis as and when they become severe or present, and miscellaneous conditions like Epstein's anomaly, etc. So starting with the pre-tricuspid shunt, we all know various types of ASDs exist: fossa avalis, sinus venosus, and primum ASD. A natural history of untreated ASD is not very good. If you look at only 6 to 10%, less than 10% children have symptoms, and it has a very low early mortality. But if you look at ongoing mortality, we have very high mortality beyond 36 years and almost 75% mortality in uncorrected patients by 50 years. And median age at death as per data goes is around 37 plus minus 4.5 years. Untreated patients develop rhythm problems, PAH by 10 years. Age at surgery, if less than 10 years, most of the time we have normal outcome, but beyond 25 years, there is 93% survival at 10 years, and beyond 40 years, if you are operating or closing the atrial septal defect, then the survival goes down to 84%. So timing is asymptomatic child, 3 to 4 years, by surgical or device closure. Primum ASD with MR, they will have heart failure early in life, so they will require treatment as per MR. So once the child has mitral regurgitation more than moderate, then the child should undergo surgery. Asymptomatic children, early surgery, and late presentation, closure is recommended if there is volume overload and if PVRI is still low and acceptable. These video won't play, these are just showing the device closure of ASDs. Usually the recommendation is weight more than 15 kilos, age more than 3 years, evidence of RV volume load, normal pulmonary venous drainage, and defects with good margins, at least 6 to 7 millimeter all around. Advantage, we all know, it doesn't create a scar, doesn't require blood transfusion, and a short hospital stay. Quickly going to post-tricuspid shunts, mainly VSDs. large PDAs. They can be large, moderate, or small. Large VSDs, unoperated, tend to become Eisenmenger, so become inoperable by 2 years of age. These are the vascular changes. If we leave the child unoperated for long, these are the thin-walled vessels in the lungs, and look at these are the plexiform lesions, and these cannot be reversed. So these are the pathological changes that progress into the lungs, and that is how the child becomes Eisenmengerized here. Same thing in histopathology, the last one showing complete occlusion of the arterioles in the lungs. So if you operate in time and if you operate late, this graph shows the probability of having normal pulmonary artery pressure with age. So that is, if we are operating children beyond, say, 12 months of age or so, then probability of having normal pulmonary artery pressures after the surgery goes down drastically. And this is the survival curve for Eisenmenger syndrome, whereas the upper one is the survival for regular VSD. So life expectancy of Eisenmenger is equally bad. So often these children should be present at 4 to 6 weeks with heart failure. So we require to treat the heart failure, treat the anemia, adequate calories, and surgical repair is now done at 4 kg or 3 to 4 months of age. PA band is solution only when patient is in extremely moribund condition or there are multiple VSDs where all VSDs cannot be closed in single go. Moderate to shunts, moderate VSDs where the child is mostly asymptomatic, then we hope for closure by 2 years, and if that's not, then we have to do a definitive repair. And if the child gets into a single episode of life-threatening LRTI, then we should go ahead and close the hole. Small VSDs, mostly medical follow-up. Surgery may be required if there is a RCC prolapse or if there is a endocarditis. Device closure only for selective groups, mainly for muscular VSDs. Perimembranous VSDs tend to have risk of heart blocks, so one has to exercise caution that one does not put a device where there is not enough adequate margin from the aorta and there is not enough aneurysmal tissue growth. Post-tricuspid shunt PDA again behaves like VSD. So surgical closure is recommended for large shunts. For non-surgical closure, weight above 8 kgs and PDA devices are commonly used. This is the Implarts device. Coils are more or less historical now. So Implarts device is very successful, and we can close large shunts also up to 18 millimeter with an 18 millimeter device. Quickly going to cyanotics, the TOF physiology. We all know this is the TOF, what the X-ray looks like. Asymptomatic patients should be given iron supplementation, beta blockers, and elective repair should be offered by 8 to 10 months. Single cyanotic spell can create havoc. So these are the infarcts in a child who had single episode of cyanotic spell. Clubbing, brain abscesses are complications of unoperated patients. This is the survival of TOF with surgery, and that's the survival of TOF without surgery. So there is a rapid decline beyond first decade. And by 30 years, more or less, almost everyone is gone. So we have best hopes to operate them early in life. So immediate intervention is required if the child has saturation less than 70, hemoglobin more than 18, and PCV above 60%. That immediate intervention could be in form of BT shunt or a corrective repair depending on the anatomy. So if the weight is adequate, pulmonary arteries are good size, we go in for a complete repair. But if weight is low, pulmonary artery anatomy is poor, then we go in for what we call is a modified BT shunt. Cyanotics with increased pulmonary blood flow is a heterogeneous group. TGAs, TGA VSD, TA PVCs, truncus, single ventricle without PS, etc. These children, I'll just take TGA as prototype. For unoperated TGAs, this is the natural life history. Intact septum, more or less everyone is gone by 1 year, and when they have VSD with PS, the survival is slightly better. So most children should be operated in time. This is the outcome of a child operated, 2-day-old, simple TGA, arterial switch, and that's the outcome at 10 years. So we'll have a normal life if operated on time. So now this limit of 3 weeks has been extended. So we are doing arterial switch, or most centers will do arterial switch at 6 weeks of age, and the LV is prepared. Beyond that, the answer is Senning repair. Problem with Senning is that we do the atrial routing, whereas the RV remains the pumping chamber for the systemic circulation. So long term is not good, because these children will develop RV failure. And by second decade or third decade, they come back to us with significant RV failure, and then are become candidates for cardiac transplant. So arterial switch probably offers the best chance. Coming on to another complex lesion, physiology. I'll just take a minute or two more. We have various subtypes, as we all know: tricuspid atresia, hypoplastic RV, DILV, etc. So basically, single ventricle is a volume-loaded hypoxic circulation, and if you leave them untreated, they have very high morbidity and mortality. This is a statement that was published in Circulation 2007. As a group of patients with unrepaired univentricular heart have poor prognosis, in the larger seizure of unoperated patients, 83 patients, Moody et al. Reported 70% with well-formed left ventricles died before age of 16, with an annual attrition rate of 4.8%. The natural history is even bleaker for patients with univentricular hearts of RV morphology, with 50% survival at 4 years. The most common cause of mortality is arrhythmia, congestive heart failure, and unexplained death. So situation is not the same today. Situation is much better. This is the survival after Fontan. So if you have a patient who comes like a tetralogy physiology, that is reduced pulmonary blood flow, if the child is beyond 3 months of age, we go for the Glenn shunt. But if the child is very, very blue before 3 months of age, then BT shunt or a PDA stenting may be required. Beyond 4 years of age, when we do the Fontan completion, the only difference for the univentricular with increased pulmonary blood flow will be that they need to undergo a PA band, followed by Glenn, followed by Fontan circulation. The longevity is expected to around mid-40s, but we do have long-term issues of liver failure in second or third decade of life, protein-losing enteropathy, etc. So one has to be careful and watch for all these complications after Fontan completion. Obstructive lesions, I have already discussed the neonatal period. Aortic stenosis, balloon dilatation, again the treatment of choice. The indications remains the same: peak gradient more than 75 and mean gradient more than 40. And pulmonary stenosis, older children, peak gradient above 40 is considered indication for balloon dilatation of pulmonary valve. Coact, gradient more than 15 is considered significant. In neonatal period, surgical repair is the best option. After second year, we go for balloon dilatation, and adolescents or more than 30 kg, we go by placing stents in the coact segment. So in conclusion, most congenital heart disease give optimum results when treated on time. Delayed treatment often gives poor survival. Early diagnosis and correct treatment are key to intact and long-term outcome. Delayed treatment is associated with morbidity, mortality, higher costs, and poor outcomes. Thank you.
Hello. Thank you, Dr. Ashutosh, for your lucid talk. And any comments and questions?
There is no comment, as Dr. Ashutosh have to leave because his flight is at 5. Now I request Dr. V.B. Singh sir to give memento to Dr. Ashutosh, because he have to leave, his flight is at 5. Thank you. Thank you. सर सामने सर इधर आ जाइए, बीच में.
Yeah, for the second talk, I invited Dr. Rishi Sethi sir, and the topic is non-invasive assessment of the CAD, myth versus reality. Dr. Rishi Sethi is the Dean Faculty of Innovation and Professor in Department of Cardiology in the KGMC.
Yeah, bye-bye. Take care. Take care. Take care.